online person. Welcome to attend the second American-Taiwan Joint Conference. Today we have a 3-hour program with 5 interesting topics, all presented by heavyweighted champions. Each topic will spend 30 minutes, including the time of Q&A. If you have the question and the comments, please use the microphone aside your seat, but just raise your hand before it, and waiting for the moderator to appointment. Okay, now let's welcome Professor Chen Shiyuan, the President of Taiwan Association of OBGYN, to do the opening remarks. President Chen, please.
Thanks, Secretary General, Dr. Huang. Dear guests and TAOG members, it is my great honor to host the second AT online conference here with you. As one of speakers, I'm honored to work with 4 other outstanding speakers to give exciting talks. Since last year, with the great support and assistance of Dr. Mark DeFrancisco and Dr. Huang Mingzao, who will also be awarded as our honorary member, we are delighted to be able to have the first American-Taiwan Congress, introducing extraordinary ACOG, American College of Obstetrics and Gynecology, speakers for our members. As the president of TAOG, I would like to make AT conference become a tradition of academic exchange and international friendship. Furthermore, I thank Dr. Verda Hicks, Dr. Sandra Carson, Dr. Lisa Hollier, and Dr. Mark DeFrancisco. Your innovative lectures will be beneficial to our participants on site and online. I would like to express great appreciation for our chairs today. Thank you for your precious time, and they will make the Congress perfect. Thanks.
Now let's welcome Professor Mark DeFrancisco. He is the past president of ACOG, and in this August, he will also be the honorary fellow of TAOG. Hi, Professor Mark. Hi, do you hear me? Okay.
Can you hear me?
Okay. Good.
Can you hear me?
Yes. Yes.
Very good.
Thank you. Go ahead, please.
Thank you. Thank you. President Chen and members of the TAOG board and the organizing committee for this meeting, distinguished fellow speakers and attendees, good morning. It is my distinct honor and my pleasure to help open the second annual virtual AT virtual conference. As you know, last year we took the very first step in what we hope will be a long journey together, creating and strengthening the bond between us through education and interaction. Today, we now prepare to take the second step as we continue that journey. I'm very proud to present today 3 of the smartest people that I know. I'm the only heavyweight because I'm overweight, but the other people that are coming from our American speakers group are very smart people representing reproductive endocrinology, GYN oncology, and maternal fetal medicine. And I know they will provide you all with excellent presentations this evening. My talk will not be a clinical scientific talk, but instead will explore a topic that arises, especially in healthcare, I think in all countries around the world, and I hope it will be helpful to you also. Since my very first visit to Taiwan more than 6 years ago, I have been in love with your country. The beautiful landscapes, the national parks, your very impressive technology, the tall buildings, the super fast train, the high-speed train, the excellence of your scientific programs and your professional society, TAIOG, are all strong magnets that pull me back to Taiwan. But most of all, the welcoming warmth of your people and the many good friends I've been fortunate to accumulate over these past few years are by far the biggest attraction for me to Taiwan. So again, this has been a wonderful relationship, and I thank you. I agree this should be a tradition going forward, and I hope that we continue this journey together. Words cannot express my gratitude to you all for the great honor you will bestow on me in August. It's been my honor, simply enough honor to work in helping to create this joint conference, but to be awarded the honorary fellowship is what we call in America icing on the cake. The cake is very good, the icing makes it even better. So I do appreciate it, and I do want to thank you for that great honor. Thank you all very much for allowing me to participate in this historic relationship, and I look forward to a very successful meeting tonight. Thank you.
Thank you, Professor Mark DeFrancisco. We very appreciate your friendship and always helping the TLG. Thank you. Now let's start the first section. It will be moderated by Professor Yu-Shi Yang and Professor Qin-Hong Shi. Both are past president of TLG and now the fellow of TLG. Okay, please.
Good morning, ladies and gentlemen. Now we will start the first session of this morning. In this session, we have 3 speakers, 1 from TLG and 2 from ACOG. And it's my honor to chair this session with Professor James Xie. I will introduce the first speaker, and Professor Xie will introduce the second and third speakers from the ACOG. The first speaker, Professor Xian Chen, is now the president of TLG and also the department chair of OBGYN National Taiwan University Hospital. Maybe some of you know the first live pregnancy from OSAF region was born in 2002 in National Taiwan University. And since then, this technique has been widely applied in Taiwan, especially for the delayed childbirth. So now Professor Chen will review the progress of OSAF region to us. Thank you. Now we please give Professor Chen a big hand and start the first topics.
Young introduction and chairman. Today I will talk about the OSAF reason for fertility preservation of female cancer patients. The advance in cancer therapies have increased the survival rate of cancer patients. The cancer treatments potentially damage their ovarian function. We started the OSAI cryopreservation program for fertility preservation of unmarried female cancer patients since 2003. Appropriate control ovarian stimulation and vitrification technique are important for OSAI cryopreservation. Most patients' cancer have only one single cycle opportunity due to time constraints before oncologic treatment. Therefore, efficient and effective to obtain sufficient good quality oocytes with safety are important. We had performed a preclinical experiment. We found the survival rates were around 95% for human in vitro mature oocytes using vitrification method. Then we performed the vitrification study using mice model, and we found the meiotic spindle of oocytes recovery 3 hours after sowing with incubation. And these pictures were selected to be our cover story of the human reproduction. We had performed oocyte freezing of human oocytes using slow methods in the beginning. And the survival and pregnancy outcome were comparable to embryo freezing. In this review article, the survival rate of oocytes from vitrification appear higher than slow freezing methods. Therefore, we have chosen vitrification as the method of choice for oocyte cryopreservation. For the control of ovarian stimulation, compared to the long protocol, a shorter protocol of GnRH agonist is more suitable for cancer patients due to shorter treatment time. We report our first live birth after single embryo transfer of autologous cryopreserved oocytes from a patient with myelodysplastic syndrome who underwent allographic peripheral blood stem cells transplantation. She delivered a normal female baby with normal weight at term delivery. On 2006, she was 25 years unmarried with pre-leukemia. Before chemotherapy, we used short protocol of GnRH agonist and triggered with HCG. We got 38 oocytes and frozen. However, she has moderate ovarian hyperstimulation, but successfully treated. After stem cell transplantation, she became premature menopause. 7 years later, on 2013, she was 32 years married. We sold the oocytes with 91% survived. We transferred one single embryo transfer with blastocyst and got a live birth with hormone replacement or treatment cycle. She has also had 5 blastocysts still vitrified and 16 oocytes frozen. For the OHSS, the HCG will stimulate corpus lutein and prevent apoptosis of them. Large amount of VEGF and IL-8 from multiple corpus lutein will act on VEGF receptor 2 of endocellular cells and induce opening of endocellular cells gaps and vascular leakage that will result in OHSS. Since 2005, the GnRH antagonist protocol get wide use gradually, can reach 70% of cycles use GnRH antagonist protocol. Antagonist protocol is commonly used in stimulation for cancer patients for its convenience and patient-friendly and safety. We use the dosage depends on the body weight, AMH, and the agonist trigger dramatically reduce OHSS due to short half-life of induced endogenous LH surge. However, a small fraction with failures and suboptimal response to GnRH agonist trigger. The effect of trigger is confirmed 12 hours after measuring serum LH and P4 level. With lower baseline LH or low LH maximum level during stimulation, we will consider dual trigger with HCG. The GnRH antagonist protocol can be used in combination with GnRH agonist trigger. They cannot be achieved by GnRH agonist protocol. And freeze-all strategy to prevent OHSs can achieve good pregnancy rate. For the estrogen-sensitive cancer, such as breast cancer, control ovarian stimulation, we can add tamoxifen. Its anti-estrogenic effect on breast tissue may benefit for estrogen receptor positive breast cancer. The letrozole can start with control ovarian stimulation to decrease serum estrogen level to be closer to natural cycles without affecting oocyte or embryo yield. And the letrozole is initiated after oocyte retrieval and continue until menstruation. The GnRH agonist induced endogenous LH may result in lower estrogen production, which may be an advantage for patients with estrogen-sensitive cancers. The use of the letrozole plus the FSH for fertility preservation in breast cancer does not appear to significantly raise the risk of breast cancer recurrence. Breast cancer ovarian stimulation protocol, we use the letrozole to decrease the estrogen level, gonadotropin to stimulate the ovary, and GnRH antagonists to prevent premature egg surge. And finally, we use the GnRH agonist trigger. This 29 years old unmarried woman with breast cancer, we use the antagonist protocol plus the letrozole, and we got the 25 oocytes. Thirty-four years old, she got married, and we sold the 25 oocytes. We performed the embryo transfer for 2 embryos, and she got a live birth. The alternative ovarian stimulation protocols with tamoxifen and letrozole did not affect the number of follicles in women with breast cancer. The mean length of the ovarian stimulation was similar among the 3 protocols. That's around 10.5 days. And also, no difference among groups in the mean number of cumulus oocyte complex and the number of oocyte bank. For the cancer patients, sometimes no time to wait for the mens to start ovarian stimulation due to the urgency of cancer treatment. So, the random start protocol has been proposed. This is consistent with a newer concept. There are multiple waves of follicle recruitment during each menstrual cycle. The ovarian stimulation, the duration for the random start usually was 2 days longer than the conventional start. If we start in the late follicular phase or luteal phase, the total dosage of gonadotropin also significantly higher. But the number of total oocytes or mature oocytes and oocyte yield rate and fertilization rate were similar between the two groups. These 38 years unmarried woman, before chemotherapy, we used the random start at the luteal phase. The progesterone is 9.4. And the antagonist protocol for shortening the time before she receives chemotherapy, and also use the letrozole to suppress the estrogen levels. And we got 9 mature oocytes vitrified and continue the letrozole to suppress the estrogen level for the breast cancer. Recently, the progestin prime ovarian stimulation can reduce the injection burden of the GnRH antagonist, and with comparable outcomes to the GnRH antagonist protocol. So the PPOS protocol will be suitable for control ovarian stimulation of oocyte cryopreservation. This 30-year-old woman unmarried with gastric cancer. The AMH is 3.7. Before chemotherapy, we use the PPOS protocol, stimulation for 9 days, and triggering with the GnRH agonist. We got 29 oocytes, and 24 is mature, and vitrification, and no ovarian hyperstimulation syndrome. So, since 2003 to 2021, we have 115 cases of cancer. The mean age was 32 years old, and breast cancer and hematological cancer were most common reason for oocyte freezing. And GnRH antagonist protocol and PPOS are more commonly used. The mean number of oocyte frozen per patient was 15, and 10 cases underwent thawing the oocytes. So the usage rate was 8.7. The mean age of thawing was 37 years old. The storage duration was 5 years. The survival rate was 82, and the fertilization rate was 76. The total live birth rate per thawing case was 20%. Compare with the social freezing, the elective oocyte freezing for non-medical reason we have reported recently. The total cumulative live births of 21 cases of 54 sexes, we have got 21 live births. The pregnancy rate was 39. For patients less than 35 years old, the pregnancy rate was 64. 36 to 39, the pregnancy rate was 42. And above 40 years, is around 17. Recently, a meta-analysis and a systemic review published in Human Reproduction by Dr. Min Nick compared to the women without cancer. On average, women with cancer had a lower return rate for embryo transfer compared to the social freezing. And also, the cancer patients seems have a lower likelihood of clinical pregnancy rate and the live birth rate after ART. So, our conclusion is the need of oocyte cryopreservation in cancer patients has increased. Determination of ovarian stimulation protocol, gonadotropin dosage, and trigger with GnRH agonist only, or dual trigger plus with HCG, require an individualized assessment. Adequate ovarian stimulation and duration, usually around 10 days, is important to obtain sufficient mature oocytes. The GnRH antagonist protocol, or PPOS, feasible for GnRH agonist trigger, can decrease OHSS complication. And the random start ovarian stimulation does not compromise oocyte age and maturity, and it reduces the time constraints. For estrogen-sensitive cancers, tamoxifen and letrozole can be used during ovarian stimulation. So, the fertility preservation, the oocyte freezing or embryo freezing, would be helpful for them to own their biological children. Thanks for your attention.
Thank you, Professor Chen. Very excellent presentation. Now we open this session for the discussion. Okay, I have a question for you. Why the return rate is low, including your data and also the system review? It's because the lifespan of the cancer patient, or did they analyze why the reason of the return rate?
So thanks for this very good question, Dr. Yang. The return rate in our studies is about 8.7, less than 10. So in Taiwan, I think another problem may be due to we have to perform IVF for married women, and so the return rate may be small. But in the other country, maybe such as in USA, they can perform the IVF for the unmarried woman, but their return rate also smaller than the social freezing. Maybe due to the cancer patients, the condition may sometimes not good as the social freezing, may be one of the reason. But in Taiwan, our social freezing also return rate is less than Western country. So maybe due to our regulation is more strict. So for cancer patient, maybe two conditions. The first, maybe due to the disease problem. And in addition, we also have the regulation in law.
Okay. And the second question is, in your data, you showed that actually the live birth rate is not so high, yeah, only around 20%. But in your lung cancer patient, in young age, especially in the less than 35 years old group, your live birth rate is around 60. The big difference is you think is due to what factors?
Thanks. Maybe the cancer patients, we have patients cancers retrieve oocytes before chemotherapy, but sometimes we have patients retrieve oocytes after chemotherapy, especially such as leukemia. They will receive multiple chemotherapy, then they come to take oocytes. This may be the first problem. And the second, maybe due to after cancer treatment, usually they received chemotherapy, radiation, so maybe also affect their reproductive function. So maybe the cancer patients have lower pregnancy rate than the normal patients for oocyte cryopreservation. But because our case number is very small, and even in the world, the case number is still small, so we cannot very conclusively this data. Thanks.
Thank you. Is there any questions from the floor? Yeah. I think the cure rate of cancer patient is become better and better in Taiwan, I think. So the need for the fertility preservation for this cancer patient, I think in the future should be more patient. But in Taiwan, we still, the patient should pay by themselves, right? It's not covered by our insurance. So for cancer patient, maybe fertility preservation should be covered by the insurance. I think it's better for their future fertility. Yes. You know, in Taiwan now, some local government, they will provide subsidy for the married women for oocyte freezing. But for cancer patients, I think it's more important.
Yes, so we will suggest the government to sponsor the cancer patient to preserve their fertility. Thanks, Professor Yang's comment. Okay.
Okay, thank you. Now we will move to the second topic. Professor Xie will introduce the speakers.
Hello, Jim. Hello, Mark. Are you available now?
How are you, James? Yes, thank you.
Fine, thank you. It's my great honor to introduce my good friend, Mark De Francisco, the second speaker of the session. And Mark is the past president of ACOG and the Secretary of Accreditation Commission for Healthcare. He got his medical education and the residency at Department of Obstetrics and Gynecology, University of Connecticut. And he now was in private practice in OBGYN for many years. He's also one of the founder of Women's Health Connecticut, Physician for Women's Health. It's one of the largest OBGYN practices in the United States, and serves as is Chief Medical Officer from 1997 to 2014. And Dr. DeFrancisco has a strong background in accreditation, as he was a board member for many years and a past president of the Accreditation Association for Ambulatory Healthcare, AAAHC. He also served as a board member and the vice chairman of the Accreditation Association for Hospitals and the Health Systems. Currently, he is a member of the board and the secretary of the Accreditation Commission for Healthcare, ACHC. Dr. DeFrancisco has published multiple articles, abstracts, and book chapters, and has been a frequent speaker on various clinical, patient safety, and the business of medicine topic until his retirement from practice. He was also an assistant clinical professor of OBGYN at the University of Connecticut Health Center. Prior to become, it's very interesting of Mark's career or life. Prior to becoming a physician, Dr. DeFrancisco has a brief career in banking and also served as a state representative in the Connecticut State Legislature. Mark's career is very, very fruitful. And the topic Dr. DeFrancisco wants to give us is when things go wrong, disclosure of adverse events. Dr. DeFrancisco, please, and let's give Mark a big hand.
Thank you. Okay, hopefully you can see that, and can you hear me? James, can you hear me? Okay, let me see. This is Mark DeFrancisco. I want to just go back a second. Here we go. Good morning, and thank you very much for your kind invitation to speak to you today. This will not be, as I mentioned earlier, a clinical scientific lecture, but instead cover a topic that is very important in healthcare, probably in most countries around the world. This topic affects patient safety, quality of care, and physician wellness. Even under the most carefully controlled circumstances and conditions, things can go wrong. Even if not preventable, these adverse events affect both the patient and the physician. And this is why, in part, when something does go wrong, we recognize that there are two victims: the patient herself, who was injured by an adverse event, and usually also the physician or the healthcare team that was involved with the adverse event also suffers from the event. Studies have shown many benefits of disclosing adverse events, especially if the result of medical errors, and fully discussing these events with the patients. This talk will briefly review the benefits of disclosing and discussing adverse events with patients and suggest the best ways to do it. I always start out with a disclosure. I have no conflicts of interest to disclose related to this topic. And I think we start out with definitions, especially we've talked about, I've mentioned adverse events, but what do we mean by adverse events? An adverse event is an injury that was caused by medical management rather than the underlying disease itself, And not only that, but it's something that prolongs the hospitalization or produces a disability at the time of discharge, or both. Adverse events can be preventable, and those typically result from substandard quality of care, a mistake that gets made, and that's something that should be preventable. But some adverse events are not preventable, and these generally relate from conditions of the condition itself or the disease process itself, where excuse me one second, there we go, where it's just a known complication that, as we all know, many procedures that we perform, we need to inform patients ahead of time that there's never 100% guarantee that there's going to be a safe or a good outcome. Some procedures and conditions have a certain percentage of bad outcomes, and patients need to be aware of that. That's what we call non-preventable. There's no way to prevent those kind of things because they're not related to substandard care. A near miss is another type of adverse event, but as the name implies, it's typically a preventable adverse event, but the patient, fortunately, the patient is not harmed. And the reason that happens is because either just good luck sometimes protects the patient from being harmed, or sometimes the error, whatever went wrong, is detected early and is fixed before it does have a chance to cause problems for the patient. This whole study of this patient safety and adverse events has really been going on for quite a few years. Over 30 years ago, a landmark study by Brennan, Leap, Laird, et al., and called the Harvard Medical Practice Study, published in the New England Journal of Medicine, talked about a random review of over 30,000 acute care hospitalized patients. What they found in reviewing all these charts were an incidence of adverse events of about 3.7%. And of those people that had adverse events, almost a third, 27% of those cases, were due to some kind of negligence. In other words, they were preventable events. So that's still a large number of people, as you extrapolate that over a larger population, that have had not preventable adverse events, but still a significant number, very significant number of people that do suffer preventable adverse events. Because of the much study that's been done since that study back 30 years ago, patient safety, quality of care, continuous quality improvement, all of these activities have enhanced our knowledge of adverse events and of quality of patient safety, quality of care kinds of issues. And what have we learned? Basically, one of the things we've learned, at least about adverse events, is that it is critically important that the event is disclosed to a patient or the family if the patient's suffered and not able to participate in the discussion. But that you can't hide these things. They need to be disclosed with the patient. And it's important not only to disclose when something went wrong, that it went wrong, but to disclose more details about the event, what actually happened. So disclosure and discussion combined really are morally and ethically necessary. I think there's general agreement from most people. Following these policies of disclosing and discussing with the patient any adverse events, what we find is that this will strengthen the physician-patient relationship, will reduce patient and physician stress, and will promote safe and high-quality healthcare by doing so, just improving the system of healthcare. What we do know from our studies also is that patients who do suffer adverse events want to have and appreciate having timely and full disclosure, including an acknowledgement of responsibility of some sort, an understanding of what actually happened, an expression of sympathy of some sort, where people do let them know that they're sorry for what happened to them, and a discussion of what's being done to prevent recurrence of this, whatever the terrible event was. The benefits of disclosure and discussion with patient, we know sometimes are a faster recovery for the patient, because at least some of the stress related to undergoing an adverse event is reduced when the patient understands what happened to them. So for many people, this leads to a faster recovery because of the increased trust between the patient and the physician, who is not hiding something from the patient. It typically maintains or even improves the relationship between the patient and the physician. At the same time, of course, it will tend to have a favorable effect in terms of decreasing the number of malpractice lawsuits. And when that happens, also the average settlement from lawsuits that still continue, typically the settlement amounts also decrease because patients understand better what happened. As far as litigation goes, I assume that's a big problem in most countries, not just in the US. Surveys show that patients are far less likely to engage a lawsuit if they perceive that an honest disclosure of the event was made to them. And of the patients that do sue, almost half of them, about 43%, were driven by a suspicion of a cover-up or by the desire for revenge. But typically that would be in a case where there is already a bad relationship with the physician, because again, the patient feels that the physician is covering something up. And as I mentioned, the concept of a second victim, adverse events frequently can produce problems emotionally and functionally for physicians or members of the healthcare team, which ultimately will limit their longevity in practice and could also really affect their stability, as many times physicians who do have a bad outcome, especially if they feel they contributed to it by making a mistake, often will lose a lot of their confidence. They will be afraid to provide care for people going forward. It can just really seriously affect negatively their practice and their own wellness. And consequently, for that reason, not only the stress that bad outcomes have on patients, but on physician and care team members also, we found that disclosure of adverse events can be an important asset for both the patients and the healthcare team's healing process, because again, it helps them understand better what went on, and it helps to rationalize it and not take it personally as much as try to figure how to avoid this problem in the future. Advocacy groups such as patient advocates, patient safety experts, ethicists, policymakers, accrediting organizations, and medical professional societies pretty much all agree now that policies relating to disclosure and discussion of adverse events are a good thing, and they do promote them. The Institute of Medicine, for instance, really over these past 30 years have been pushing proposals for a national focus on patient safety. And they really wanted to even create a mandatory reporting system. Because in the US, we have 50 different states, we have 50 different sets of laws in different regions and states. But in some states, there is definite mandatory reporting of abnormal or unexpected results. And ultimately, the IOM is interested in raising standards and expectations for safety improvements at the national level and helping to create safety systems in healthcare organizations. So systems are a very important concept here. The Joint Commission and other recognized accreditation organizations also have a strong standard that really puts the burden on the physician who's responsible for managing the patient's care to inform the patient about any unanticipated outcome of care, treatment, and services. And by unanticipated outcomes, obviously, we mean adverse events, something that you didn't expect to happen. The American Medical Association also has in its code of ethics a statement that a patient who suffers a significant medical complication that may have resulted from a physician's mistake, when that happens, the physician is ethically required to inform the patient of all the facts necessary to ensure that the patient understands what has occurred. And again, this is straight from the AMA. And ACOG supports all of these efforts. ACOG has a committee opinion, 681, that again seeks to assist members of ACOG and people to get to read this committee opinion in understanding the value of disclosure and discussion. And large parts of my talk tonight are really based on information that's in Committee Opinion 681. We know from, again, a lot of study in this area that there are many barriers to disclosure when something does go wrong. The doctors in particular are very worried about reporting an adverse event. They are fearful of being punished. They are fearful of some kind of retribution. They many times lack the training to know how to approach the patient when something's gone wrong. And there is in many institutions still a culture of blame, meaning that when something bad has happened, it's too easy to just blame the doctor or blame the nurse, basically to rather than say what went wrong and let's study it and let's prevent this in the future, they look to punish somebody as opposed to fixing the system. And of course, there's always the fear of being sued, a fear of lawsuits. In fact, until more recent times, when somebody did have an adverse event occur and a patient was injured, many attorneys would advise the physician to not talk to the patient about the accident, about whatever happened, on the theory that the patient might take whatever you say as an admission of guilt, or that you might be tempted to misrepresent something to the patient and not tell them the truth. So for various reasons, they would tell people the opposite of what we tell people now. Now we try to explain to people how important it is to talk to the patient and to go over disclosing exactly what happened. And we're going to get into that and how we do that. To reduce barriers that we just talked about, healthcare facilities need to establish what we call a just culture, a justice-based, a just culture, or a blame-free culture.
Mark, we could not hear from you.
What happened and figure out not only, well, two things. One, was there a mistake made? And again, that's not so much to punish somebody, but to figure out what needs to be corrected to prevent this in the future. And sometimes the mistake could be very simple, that the physician or healthcare team member used the wrong drug, took the wrong instruments, whatever, something that was a mistake, and that's easier to fix because you won't do that again in many cases. But other times you find a problem where you say, well, it's really understandable why this person used the wrong instrument or the wrong drug, because the drug that we needed was the next drug over, or maybe the spelling of the words are similar. So the system of how healthcare is delivered sometimes can be improved so that the mistake that occurred cannot be reproduced in the future if you've changed the system to kind of prevent that from happening. So that's the benefit of reporting and studying near misses and adverse events, that it helps you to continuously improve quality. But even then, removing blame and substituting fixing the system does not eliminate individual responsibility. So certainly gross negligence, that person still has to be admitting to gross negligence, and certainly any reckless behavior there should be zero tolerance for. So being a blame-free culture does not give anybody license for reckless behavior or whatever, but it does de-emphasize punishment, and it emphasizes fixing the system to prevent these problems from recurring in the future. Education programs created by healthcare organizations, insurance carriers, especially malpractice insurance carriers, and many states in public health departments have developed programs to educate physicians about disclosure and how to discuss adverse events with patients. For instance, Harvard has a consensus statement of the Harvard hospitals, again, very much like the title of this talk, when things go wrong, how to respond or responding to adverse events. These are valuable education tools so that, again, not only the physicians, but other members of the healthcare team can learn about how to disclose and express sympathy or even apologize. Copic is an insurance company based in Colorado, very physician-friendly and very supportive of physicians. And years ago, they developed a program simply called the 3 R's. And the 3 R's represent recognizing a problem, responding to a problem, and resolving any unanticipated medical event. So when a patient does have a wound infection, bleeding postoperatively, return to the OR, or anything like this, clearly it's got to be recognized as soon as possible. It's got to be responded to and fixed right off the bat, and then resolve any unanticipated events, meaning at that point to make sure the patient understood what happened and make sure that if for instance, the adverse event contributed to the patient staying in the hospital longer, perhaps part of the resolution for that patient might be to provide some funding or money to help pay for childcare, for instance, or other things they might need at home that they're not able to do because they're in the hospital longer. So that's typically what's meant by resolving any unanticipated problems caused by adverse events. It's a very good program. So ACOG has talked about framing the discussion. How do we set up a discussion with a patient when we've had an adverse event? And typically, like many things, we look at who, what, where, when, and how. So who should actually do the discussing or lead the discussion with the patient? And generally, it's felt it should be the attending physician who's responsible for that patient. In many cases, unless the person who, let's say, did the surgery was not the normal physician, the regular physician for that patient, but a special consultant called in that case, whoever has the most trusted relationship with the patient should lead the discussion with the patient. And again, if not available, at least a senior member of the healthcare team should be there. The circumstances of what the event actually was will often dictate who else should be there. For instance, again, if it's a surgical mishap and somehow it's related to anesthesia, then clearly the anesthesiologist should be in that conversation also with the patient. And generally, whenever there's a conversation with patients about adverse events and follow up on that, at least 2 members of the team should be involved with any discussion, mostly to not get into a 1 versus 1 situation, but mostly to be sure that there's a good record of what the conversation was between the healthcare team and the patient. So it is recommended that at least 2 people be involved. What should be communicated? Very simply, no guessing, no hypothetical hypotheses or whatever, but basically only the facts that we know are true should be communicated. But because sometimes not all the facts are known initially, and many times cases involve some study, patients need to be reassured that as additional reliable information is obtained, they will be notified promptly and understand in the details what else has been discovered. When typically disclosure should be timely. It should be as soon as reasonably possible. Again, while emphasizing to patients that this is an ongoing process of communication, and again, they're going to talk to the patient initially, but there'll be further conversations as more information is discovered. Clearly, this should be a very confidential setting where the team could meet with the patient, and it should be a comfortable place where the patient should be a quiet place, a place where the patient is comfortable. And how, of course, patient dignity must always be respected. Disclosure conversation should include at least sympathy for acknowledgement of what the patients and their families have experienced. You don't necessarily have to apologize, and we're going to get into that in a few minutes, the difference between sympathy and apology. But at least the patient should understand that all the members of the healthcare team are sorry about what happened and sorry that they're suffering from this complication. And then general guidelines for discussions with the patients more specifically. Again, the facts we talked about, the facts need to be presented. They should be gathered and investigated as timely as possible to be sure that only the most accurate information is presented. Especially if the event is serious, disclosure should be as soon as possible. But again, because all the facts are not always known immediately, we must always promise the patient to return with more facts when they are available and proven to be true. Confidentiality, we already talked about briefly. Confidentiality must be preserved. The meeting should be private, comfortable, and many patients do need a support person present. It's probably a good thing anyway, because again, just like when a patient sees you in the office and there's something serious going on in the clinic, sometimes the patients will be nervous and will forget what they've heard. So it's often a good idea for the patient to have a support person with them that they're comfortable with to participate in these conversations, just as a good memory check and somebody who could also confirm what was said. The disclosure process itself should occur as soon as reasonably possible. Again, while emphasizing that it's going to be an ongoing process. The treating physician or someone the patient has a trusted relationship with should do most of the discussion. And many times the hospital or the institution may require the presence of a risk manager too. And keep in mind, the risk manager for the hospital, for instance, is not a person who should be there to protect the hospital. That person has to be there to represent the hospital and to be sure that the patient understands that the hospital or healthcare institution is concerned about the patient, and the risk manager is there to see what can we do to make things better for you. The focus of the conversation should always be not on hiding things or covering things, but should always be on the patient's condition, how are you doing, and treatment plans. And that's the main idea. Style of conversation, again, patient dignity must always be respected. Terms should be not medical jargon, but they should be understandable to the average patient who is not a physician, and should minimize any stress that the patient may be going through. Basically, we need to explain to the patient what happened and how it did happen, explain why it happened if we understand at that point why it happened. And certainly, most importantly, we know patients also want to know what's being done to prevent this from happening to somebody else in the future. These are all important pieces of information the patient needs to get. I did mention briefly about sympathy versus apology. Sympathy is simply acknowledging the suffering. Gee, I'm so sorry this has happened to you, and I'm so sorry you're suffering this. Apology is different. Apology is taking accountability for that suffering. I'm so sorry that my mistake did this to you, and I'm responsible for this. So as you can understand, expressions of sympathy are always appropriate because no matter whether this was preventable or not preventable, it's totally appropriate to tell anybody, we're sorry you're going through this. The appropriateness of an apology, however, will vary from case to case. If it's something that you really made a mistake and you're sorry for it, you recognize it, you've explained it to the patient, you say, I'm so sorry that my mistake caused this, and I want to apologize to you too, because I wasn't better than I was. Now from province or state to state, there may be different rules about apologies, because in some cases, attorneys get very nervous when somebody apologizes to a patient because they say that's an admission of guilt, and if you wind up going to the courtroom, they're going to use that against you. So we actually have some states in the U.S. that have passed laws that basically free up the physician to make the apology, because they specifically say in these new laws that a physician apology cannot be construed in a court of law as an admission of guilt. So it's a protection for people that still want to apologize and not hurt their case legally if there is a legal case. Anyway, let me just kind of start to recap because we're running near the end of our time here. Multiple studies have shown disclosure and discussion policies are very good things. The number of lawsuits have declined about 50%. Because of that, defense costs and amounts of settlements even have also declined significantly. In cases that were brought to the court, settled more quickly, saving everyone time, money, and stress. So in general, this whole system has improved the way even litigation occurs. But it really is not about the money. The disclosure of adverse events, as I mentioned earlier, is critical to creating high-quality healthcare and protecting the integrity of the physician-patient relationship. When things go wrong, that's the time to figure out why it went wrong and how can we improve the system to prevent that from happening again. And all healthcare providers should establish programs to study these events and to educate patients, healthcare providers, and families about it. The bottom line, when things go wrong, we have to make them right. We must be sympathetic. We should apologize if we made an error, and we should never be afraid to disclose the error. Patients will trust us more if they see we are honest, and preserving the physician-patient relationship is good for the patient and for us. I think I'm going to end there. I thank you very much for your kind attention, and I'm going to release my screen here, I think, if I could do that right.
A wonderful speech and a very important lecture. And I think the disclosure of adverse events is very important for every doctor around the world. It's also important in Taiwan. And any question from the floor? Dr. Wu, please.
Hello, Professor DeFrancisco. I have a question. Some doctors refuse to follow these rules. Others doctors continue to create use their job secret. You call that they are face the punishment. Before, we are very afraid of the patient dignity and the unreasonable demand for money. So I afraid the court sentence guilty, so we can't disclose automatic comment. 25 years ago, I had unfortunate experience this. My patient died after giving birth suddenly. I was very shocked. This case, it troubled me for 3 years. It made me unable to eat or sleep well, and also affected my number of patient visit deeper down. So I was deeply impressed. After listening to your super speech, I got to change my mind. I know what I should do to promote patient and physician relationship. The literature is a benefit for me a lot. Thanks.
Thank you. Was there a question there too? That was a comment, no question?
Any more questions? Professor Huang?
Okay. Thank you.
Good night, Mark. I'm Dr. Huang, Ming Zhang Huang. Good to see you.
Ming Zhao, how are you?
Yes, a very excellent speech. We are talking about the second return because the medical staff may suffer from the adverse event. In real world, how can you care the medical staff from the adverse event?
How do you?
We are talking about the second return, right? Because the medical staff maybe suffer from the medical adverse event. Yes, some medical students must provide the caring process to their staff to prevent they are living from their high risk job, right? In real world, how can you do?
Yeah.
In the process?
Well, that's part of. I think part of it is getting people involved in the process of the people that were most closely involved with the case should be in the discussions with the patient. But sometimes you do need professional help. You do need maybe a psychologist or a counselor of somebody, some sort, to help. If the healing process itself of just discussing things with the patient in an open way, if that's not enough, because people still are victimized, the medical staff, then I think the health systems have to understand that they do need counselors on the staff that will sit down and have some therapy sessions, some psychotherapy, talking sessions usually. And people have to understand that they need to know that they weren't guilty. They didn't cause some problem. This is the natural order of things, that there are complications that do occur, and especially if it was a non-preventable, it's something that they didn't cause to happen. Somebody that has bigger trouble with it sometimes are people that maybe caused the mistake. And again, they have to learn. Some people are just crushed by that and they cannot keep working because they don't want to do that to somebody else. But other people who could be healthier possibly could be counseled enough to restore their own self-confidence and to feel good again. But it does require some level of psychological support, I think.
Thanks, Mark. Because time is limited, so we have to close the topic. And thank Mark. Please give my best regard to Helen. We are looking forward to see you in Taichung.
Thank you.
Thank you. Thank you so much.
Same here. Thank you very much.
See you. Let's move to the third topic of the session. And the speaker is Professor Sandra Carson. She's now the Vice President of ECOX Education. And she's also Associate Editor of American Journal of OBGYN, the Great Journal, and the Editor-in-Chief of Sexuality Reproduction. 2019 Educator of the Year by the American Society of Reproductive Medicine. 2020 Hero of the Year by the Worldwide, and the Vice President of American Board of LOBGYN, elected Vice President of ECOG, and President of American Society of Reproductive Medicine, and Secretary General of the Society of Gynecological Investigation. She's also a member of FDA's Reproductive Drugs Advisory Committee and the FDA's Center for Devices and Radiological Health, and the President's Council on Bioethics. Another topic, Dr. Carson will give us is the non-surgical diagnosis and the treatment of ectopic pregnancy. Dr. Carson, please.
Hello, I'm Dr. Sandra Carson from Yale
welcome.
University Medical School, and I'm thrilled to be with you today. Thank you to the organizers of this conference for inviting me. What I'd like to do today is talk to you about the non-surgical diagnosis of ectopic pregnancy. After this discussion, you should be able to understand the disparities in the prevalence of ectopic pregnancy and diagnose ectopic pregnancy without surgery. I don't have any perceived or real conflicts of interest. Long ago, ectopic pregnancy was a surgical disease, and here's a laparoscopic picture of an ectopic pregnancy, which was then removed and sent to pathology. But modern management has changed, and it's largely through a non-surgical diagnosis that it has changed. Because after we diagnose ectopic pregnancies without surgery, we can treat it medically with methotrexate and reserve surgery only for those complicated cases. Currently, the prevalence is really unknown. In the United States, the medical cases of ectopic pregnancy are not recorded, but probably we see about over 100,000 cases per year, and it still remains the cause of about 5 to 6 maternal deaths and costs us billions each year. There are certain groups, African Americans and Hispanics in the United States, which have a higher prevalence of ectopic pregnancy, and we're not sure whether this is because they have lower access to medical care or live in places where they are not diagnosed early enough to treat them medically. And the key to successful medical therapy is early diagnosis. Today, we'll learn first that the key to early diagnosis is suspecting an ectopic, and the non-surgical diagnosis requires a serial HCG, a transvaginal ultrasound, and a manual vacuum aspiration of the uterus. And I'll tell you the importance of each of these modalities in making the diagnosis. Once the diagnosis is made, we choose a 2-dose regimen of methotrexate, which we won't have enough time to talk about today. We reserve surgery only for those complicated cases. Now, it's not surprising that patients who have a previous ectopic have a higher risk of having another. Also, patients who have an intrauterine device for pregnancy control and contraception also have a higher risk. This is not because the IUD increases ectopic, but because so few people get pregnant in the uterus with an IUD that anybody who gets pregnant wearing an IUD is more likely to have an ectopic pregnancy. Also, prior tubal surgery or tubal disease increases the risk, as does postcoital contraception. You would probably be surprised to know that ovulation induction through assisted reproductive technology also increases the risk, as does a history of prior spontaneous abortions of intrauterine pregnancies. And cigarette smoking also increases the risk of ectopic pregnancy. So if patients have a history or fit into any of these groups, they're the patients who get pregnant that you should suspect an ectopic with and search for it. Early diagnosis begins with a serial HCG for 3 reasons. The first is to assess the pregnancy viability. If there's no HCG rise in 48 hours, that suggests a non-viable pregnancy. Not an ectopic, just a non. Kurt Barnhart, leading a group of investigators in Philadelphia, found in normal intrauterine pregnancies the rise every 48 hours in HCG. And they looked at the minimum, average, and maximum rise in 24 hours in normal pregnancies. The first study recorded here was done in 2003. However, the group later gave an update of this study and found that 33% of HCG levels will rise in 48 hours when the HCG is 3,000 MIU per ml. When the HCG is less than 1,500, the HCG rises 49% in 48 hours. So what this means, if patients in early pregnancy, when their HCG is low, have less than a 50% rise in HCG in 2 days, that is a non-viable pregnancy, because viable pregnancies have that rise. So when the HCG fails to rise in this area, we can say that it's non-viable, and that gives us the ability to do a manual vacuum aspiration. However, we must take caution if we suspect a multiple pregnancy. Patients who are on ovulation induction drugs, who have polycystic ovarian syndrome, and also who have a multiple embryo transfer are at risk for a multiple pregnancy, and this baseline HCG rise may not occur, and the pregnancy still could be non-viable. So these numbers that I showed you were only for a viable pregnancy. The second reason to perform a serial HCG is to time the transvaginal ultrasound. Now for this, you have to know at what level of HCG in your hands, you will always detect an intrauterine pregnancy. We'll talk about that. We usually begin looking for intrauterine pregnancies when the HCG is over 2200 MIUs per ml. If we find there is no sac when HCG is greater than 3500, we know that that is a non-viable pregnancy. This is called the discriminatory zone of pregnancy. And this is the lowest HCG value at which you can always detect an intrauterine pregnancy. So if it's above, the HCG is above your discriminatory zone value and you see nothing in the uterus, then you know that pregnancy is non-viable. Now it may be non-viable outside the uterus, or it may be a spontaneous abortion, but it is non-viable. And finally, HCG is performed also to assess the curettage effect. HCG drop after a curettage suggests completion of a spontaneous abortion. It may be spontaneously aborted out of the uterus or out of the tube, but if HCG drops, it means that spontaneous abortion has been completed. The second test in this series is the transvaginal ultrasound. We do it for 3 reasons. The first is to detect an intrauterine gestation above the discriminatory zone. Again, Kirk Barnhart and his Philadelphia group looked at the utility of ultrasound when a discriminatory zone in their hands, 1500 MIU per ml, occurred. So when they did an ultrasound above that level, 96% of the time, if they called it an intrauterine pregnancy, they were correct, which means that 4% of the time, they called an intrauterine pregnancy incorrectly above this level. Look at ectopic pregnancy. Only 86% of the time could they diagnose ectopic pregnancy by ultrasound when the HCG was above the discriminatory zone. Now, when they were below the discriminatory zone, they could often see an intrauterine pregnancy. Here it is with an empty sac. Here it is with what they call the spontaneous abortion. And look at their numbers. If they said it was an intrauterine pregnancy and called it a spontaneous abortion, they were always right. So they knew that if the pregnancy was a spontaneous abortion, even at low levels of HCG, they were correct. However, if they called it an intrauterine pregnancy at these low levels, they were right only 80% of the time, and 60% of the time if they called it an ectopic. So ultrasound is not a good way to diagnose ectopic pregnancy with one exception, and that is if you see cardiac activity in the adnexa on ultrasound, that will diagnose ectopic pregnancy, but not by an empty sac or a pseudosac in the uterus or even something in the adnexa. Ultrasound is good, however, once the diagnosis is made to measure the ectopic pregnancy. You can see in our own hands, we did a series of 100 patients with an ectopic pregnancy, and we found that we could measure all ectopic pregnancies over 2 centimeters that we saw and diagnosed by ultrasound. If the ectopics are greater than 5 centimeters, then they're ineligible for medical treatment. Here is an ectopic pregnancy. You can see the uterus and the fallopian tubes with the fetus. And this particular patient measuring the ectopic was greater than 5 centimeters, so she went to surgery and you could see had her ectopic pregnancy removed. Now this is a relative contraindication, and it is possible that if a patient bleeds inside that ectopic pregnancy, it will be larger on ultrasound, and if there's no heart rate, you can carefully also use methotrexate. And finally, we use transvaginal ultrasound to detect adnexal cardiac activity. This is the only way, as I've said before, that we can diagnose ectopic pregnancy with ultrasound. Here's why. Here is a uterus on ultrasound with what looks like an adnexal mass that has a fetus in it and a gestational sac. But look what it actually was when we saw it on ultrasound. It was a hydrosalpinx next to the corpus luteum of a spontaneous abortion. So ultrasound is not a good way, unless there's cardiac activity, to diagnose ectopic pregnancy. The diagnosis largely is made by a manual vacuum aspiration and a uterine curettage followed by an HCG. So if we do a manual vacuum aspiration, which can be done in the office, we look for villi floated in saline, and we do send it for permanent histologic section, but we do not wait for the results to make the diagnosis. We look for the post-curettage HCG drop to diagnose spontaneous abortion and therefore rule out ectopic pregnancy. So if the HCG does not drop after a uterine curettage, that diagnoses ectopic pregnancy. And this is how the diagnosis is made. Again, Dr. Barnhart's group looked at 719 subjects who were diagnosed with a complete miscarriage, spontaneous abortion, and followed them until their serum HCG was confirmed to be less than 5. And what they found, that HCG decreases greater than 15% in 12 hours. So if the HCG doesn't drop 15% or more after 12 hours from the manual vacuum aspiration, then that is not a fall in HCG. So the correct diagnosis of ectopic pregnancy often requires evacuation. Visualization of adnexal heart rate is usually not possible, and you do need a curettage to rule out spontaneous abortion of an intrauterine pregnancy. And this can be also diagnosed by removal of the tissue, seeing villi, and the spontaneous abortion is diagnosed also by a fall in HCG 12 hours or more after a uterine curettage. Nearly 40% of ectopic diagnosis is incorrect without curettage. So let's look at a summary of what we said. We follow serial HCGs in patients at risk for ectopic pregnancy until their HCG is 2200 or greater. We do a transvaginal ultrasound in those patients. If the HCG is less than 2200, then we continue the serial HCG until making sure that there is a normal rise. As long as it rises greater than 50% when it's less than 1500 or greater than 35% when it's greater, then we'll schedule the scan when the HCG is over 2200. If the scan shows an intrauterine pregnancy, we stop following the patient for ectopic. If we see an empty uterus and the HCG is greater than 3500, that diagnoses a non-viable pregnancy. Now let's go back for a minute and look when our HCG does not rise normally, we then also diagnose non-viable pregnancy. Now, this doesn't tell us where the pregnancy is. It just says that it's not going to be a baby. So that will allow us to do a uterine curettage or a manual vacuum aspiration. If the HCG falls after that procedure, it's a completed AB. It may have been an ectopic pregnancy, or it may have been a completed intrauterine pregnancy, but it's no longer putting the patient at risk. If the HCG does not fall 15% or more, or it rises, that diagnoses ectopic pregnancy. The ectopic pregnancy, again, is made by that drop in HCG, that rise or non-drop in HCG after the curettage. Now, we, when I was at the University of Tennessee in Memphis, we took a group of patients just like this. After we had finished the first trial of methotrexate in the first 100 patients in the United States back in 1988, and we made the diagnosis of pregnancy just like this. We randomized them to a treatment laparoscopy when they had this diagnosis, and this was to confirm this algorithm. 17 patients had had a confirming laparoscopy, and 17 had no laparoscopy. All 17 patients that we diagnosed non-surgically had an ectopic pregnancy. So we treated both groups with methotrexate. And the reason we did this was we wanted to make sure that it was the methotrexate indeed that was treating the ectopic pregnancy, because in our prior 100 cases, we had to do a confirmatory diagnosis of laparoscopic diagnosis of ectopic pregnancy and then wake them up and treat them medically. This was the first time it was done, and we didn't know whether methotrexate would be successful. So all 34 patients uneventfully resolved. So this study showed us that indeed our medical diagnosis was correct, and also that it was the methotrexate and not just disrupting and interfering anatomically with the methotrexate through laparoscopy that was the treatment. Methotrexate itself indeed did treat the ectopic pregnancy. Excuse me. So pregnancy of undetermined location may be diagnosed with a non-surgical algorithm requiring a serial HCG, a transvaginal ultrasound, and a uterine evacuation. No drop in HCG after that uterine evacuation is what diagnoses the ectopic pregnancy. Thank you very much for your attention.
Thank you, Professor Carson, for your wonderful and very important lecture. And we open to the floor. And any question? Dr. Xu? Please identify yourself.
I'm Dr. Xu from the Taiwan Adventist Hospital in Taipei. First of all, I would like to thank Professor Carson's and different and very impressive presentation on the ectopic pregnancy. As you know, when we treat the patient in the reproductive age with abdominal pain, usually we do the pregnancy test first, and then we probably follow up this kind of patient with that beta HCG or and ultrasound to find out that is ectopic or IUP. And several years ago, I read a special case in the literature, and they showed that the patient pregnancy test was negative, but finally they have an operation, laparoscopy operation, and find out come out is ectopic pregnancy. So did you have this kind of case in your hand? And as we know, the ultrasound investigation for the early pregnancy, the early pregnancy can be divided in 5 categories. One is definite IUP, second, a possible IUP, third is definite ectopic pregnancy, and the fourth is probably ectopic pregnancy, and finally is pregnancy of unknown locations. So I think that is literature's report is belong to this kind of category. So how do you handle this kind of rare case, ectopic pregnancy with negative pregnancy test?
Well, the key to managing ectopic pregnancy, or really any kind of pregnancy of unknown location, is to begin early. I suspect that what happened in the patient who had the negative pregnancy test, I would bet that this patient had an old, if you will, old ectopic, in which the ectopic itself and the placenta itself had died, had begun to not communicate anymore with the maternal vasculature system, and was waiting to be reabsorbed by the body, or perhaps just calcified and been in the tube. So the key to ectopic pregnancy is first to follow patients early with that serial HCG. Once that HCG doesn't rise normally, then that becomes a non-viable pregnancy. If the pregnancy is not viable, it allows you to do a uterine evacuation. And when HCG falls after that uterine evacuation, that means it was in the uterus. Now, I suppose in this case, it would have fallen, but it probably was an old ectopic and the HCG was negative anyway. So it probably did not put the patient at risk to rupture. And that brings up a second point. The pregnancy that has uterine curettage, if the HCG does not drop or rises, plateaus or rises, that means that it's somewhere else. It could be in the ovary, it could be in the tube, it could be in the abdomen. But as long as it's communicating with maternal vasculature, the methotrexate will reach it, and it'll be early enough to be successfully treated with methotrexate in over 95% of cases.
Thank you so much. Any more questions?
Thank you.
Thanks, Professor Carson. Wait. Professor Huang, please.
I'm John Jianpei Huang, the Secretary General of TLG. Thanks, Professor Carson, for your very comprehensive speech. I have 2 questions. The first one is, what is the rate of the medical treatment in your institute? The second question is, in surgery case, is there still a role for subinguotomy with removal of ectopic pregnancy tissue via laparoscope? Thank you.
We diagnose all patients, or we attempt to diagnose all patients with the protocol that I showed you, and we treat all of them with methotrexate unless they have a contraindication. And that contraindication, we haven't really been able to talk about that, but that includes unstable hemodynamic instability, elevated liver and enzymes, of course, allergy to methotrexate, and a non-reliable patient. But we are able to treat over 95% of patients with ectopic pregnancy with methotrexate. There is a role for both salpingectomy and salpingotomy in ectopic pregnancy. If a patient has an ectopic pregnancy after a tubal ligation, then she's best treated with a salpingectomy. If she has an ectopic pregnancy and would still desire pregnancy, and ends up having to have surgery, then a self-angiostomy is the most appropriate procedure for her. And thank you so much for your attention, and I'm very honored to be able to accept this information and share it with you.
Thank you so much. Let's close the session and give Professor Carson a big hand again. Thanks. Thank you so much. And thank the audience, and let's close the session, and we have tea time later. Please enjoy your coffee and the tea and the dessert. Thank you. Thank you so much.
Our moderator is Professor Shichen Huang and Minzha Huang. They are both the past president of TLG. Okay, so Professor Huang, please.
She was graduated from medical school of University of Illinois. She has residency training in the Union Memorial Hospital, Baltimore, and she has fellowship training at Duke University, gynecological oncology, and also have medical education research fellow at CGEA. Today, his topic is endometrial intraepithelial neoplasia. Professor Hicks, please.
Good morning. I am Dr. Berta Hicks, and I am president of ACOG, and I'm delighted to be here today as part of your video conference to speak on the management of endometrial intraepithelial neoplasia. I have no disclosures other than my current role at ACOG as president, and I do receive a board stipend for this role. My objectives today are to review the definition of endometrial intraepithelial neoplasia, to discuss its diagnosis, and to review the clinical consensus guidelines recommending treatment options for endometrial intraepithelial neoplasia, as well as review methods to prevent. This lecture is based on the American College of Obstetricians and Gynecologists clinical consensus document, which is titled Management of Endometrial Intraepithelial Neoplasia, Atypical Endometrial Hyperplasia, which is in press with the journal Obstetrics and Gynecology. The consensus recommendations are broken into 5 broad categories, which are titled Detecting Concurrent Cancer, Surgical Management, Non-Surgical Management, Follow-up, and Counseling Patients on Lifestyle Modifications. And so we will go through each of these consensus recommendations. And you will notice I have highlighted these recommendations in the reddish color. And so as we go through this presentation, you will see the consensus recommendations highlighted in this color throughout. Endometrial intraepithelial neoplasia and atypical endometrial hyperplasia are essentially the same pathologic finding depending on the classification system which is used. This lesion is important because it is the precancer lesion most common to type 1 adenocarcinoma of the endometrium. This photograph shows the comparison and contrasting to a benign change of the endometrium to this endometrial intraepithelial neoplasia, atypical endometrial hyperplasia. The pathologic findings included the crowded glandular architecture, as well as, if we had a higher powered view, the altered epithelial cytology and entrapped non-neoplastic glands. In addition, pathologists could do additional immunostaining to detect loss of P10 or PAX2 or mismatch repair proteins. The etiology of this precancer change is understood to be estrogenic stimulation of the endometrium unopposed by progestins. This causes the proliferation of the glandular epithelial changes and with the resulting atypical hyperplasia. The diagnosis of hyperplasia is a biologically distinct finding from the precancerous endometrial intraepithelial neoplasia or atypical endometrial hyperplasia. And the distinction between benign hyperplasia and the premalignant findings is important, as each condition has differing cancer risks and interventions to avoid undertreatment or overtreatment of this disease process. So first, in our clinical consensus guidelines, we're going to talk about the diagnosis. And this first recommendation of the consensus is very important, and I think it's probably the most important change or recommendation in this entire talk. And why this is so important is because we have used office endometrial biopsies as a standard in diagnosing the difference between endometrial hyperplasia and the finding of the precancerous endometrial intraepithelial neoplasia or atypical endometrial hyperplasia. And this is important because with the finding of endometrial intraepithelial neoplasia, upwards of 30 to 50% of patients at the time of hysterectomy will actually have an underlying cancer diagnosis. And so this current consensus recommendations is to exclude a concurrent cancer, and it is recommended that hysteroscopic examination with further sampling of the endometrium be performed when an endometrial biopsy from the office identifies this precancer change, to rule out a cancer diagnosis, because the surgical approach would thus be different, as well as the potential non-surgical approach. Next, we'll talk about the treatment of surgical management. Consensus recommendation for surgical management has not been changed, as the primary management for atypical endometrial hyperplasia or intraepithelial neoplasia is hysterectomy. And also a caveat that's very important with the hysterectomy is that a supracervical hysterectomy should not be performed. And the reasons for these two recommendations: the primary objective is to rule out a cancer. As we said in the previous slides, is that upwards of 50% of patients with the diagnosis of this atypical endometrial hyperplasia will have a concurrent cancer diagnosed. That's the reason for the recommended hysteroscopic evaluation and biopsy. But the secondary recommendation is to prevent a cancer from forming in the future. And so we know that if this is untreated, the risk to develop cancer is a risk of up to 8% per year. So hysterectomy is the definitive recommended treatment. And no supracervical hysterectomy. This photograph shows the example of a benign endometrial cavity, but the lower uterine segment and upper endocervix have the finding of the hyperplastic change, and had a supracervical hysterectomy been performed, a good portion of the hyperplastic atypical changes would have been left behind. And so the supracervical hysterectomy may not have assessed the lowest extent of the lesion, thus the importance of a complete hysterectomy with removal of uterus and cervix to be performed. Other surgical considerations at the time of hysterectomy include the decision regarding oophorectomy. And this should indeed be a shared decision-making process with the patient. I do think that if a preoperative hysteroscopic assessment with biopsy ruled out a cancer diagnosis in a premenopausal woman, then considerations for preserving ovarian function certainly would be medically advantageous to the premenopausal patient. However, if there had not been definitive evaluation with a preoperative hysteroscopic assessment and you have that up to 50% risk of a concurrent cancer being diagnosed and not have been identified preoperatively, then a discussion to consider oophorectomy, may be appropriate, as well as, for the postmenopausal patient, discussion regarding oophorectomy. Another recommendation is to consider having an intraoperative pathology assessment of the uterus at the time of hysterectomy to rule out a occult cancer. Another surgical management recommendation is no performing endometrial ablations for the diagnosis of atypical endometrial hyperplasia or intraepithelial neoplasia. The rationale is because of the incompleteness of any ablation to totally remove the endometrial lining, and thus there is a high risk of persistence of the atypical endometrial hyperplastic changes, as well as difficulty in future abnormal bleeding episodes because of scarring that can occur within the endometrium that may result in inability to adequately evaluate the endometrium if abnormal bleeding occurs. So now we're going to shift to non-surgical management of this atypical endometrial hyperplasia and intraepithelial neoplasia. Clinicians should recommend progestational agents in treatment for these diagnoses for patients in whom hysterectomy is not an option. Studies have found that there certainly are high rates of disease regression with the use of progestational agents, and there are multiple agents that are available, both oral and intrauterine or combined modes of administration, and the regression rates are very high in multiple studies showing regression up to 60 to 90%. And it is important to note that continuous use of the progestin therapy is important. It is definitely better than a cyclic type of therapy. This is a table of current recommended dosages of progestational agents for the treatment of epithelial, intraepithelial neoplasia or atypical endometrial hyperplasia. And it includes Megace at 40 milligrams daily up to 160 milligrams daily, Majoxyprogesterone at 10 milligrams daily, levonorgestrel IUDs, and the IUD recommended is the 52 milligram IUD with a delivery rate of 20 micrograms per day. And the final recommendation of agent is the combined use of the IUD combined with majoxyprogesterone acetate of 10 milligrams per day. The data on the superiority of any one of these recommended agents are lacking, and limited data suggests that the intrauterine progestational administration may be associated with a higher rate of disease regression. And we just stated that consensus recommendation regarding the combined use of intrauterine with the associated oral administration may provide some benefit. So just a little bit more information on the Ling IUD. Studies definitely demonstrate a higher regression rate with the norgestrel IUD when compared to treatment with oral progestins alone. Though potentially less effective, continuous oral progestins do have efficacy in treatment of this atypical endometrial hyperplasia. And one study is observed an improved regression rate with the combined use of the intrauterine and oral progestins, showing that the combined use demonstrated up to an 85% response rate in comparison to the progesterone-releasing IUD alone of 55% response rate. And this was a study recently reported in 2021. Compared to systemic therapy, adverse events with the IUD are less common, and patient adherence with the IUD is higher with less associated weight gain, which may occur with the oral progestin agents only. Final recommendation with non-surgical management. There is insufficient evidence to recommend one of these formulations, as I said previously, because to date there have been no direct comparison studies between the different oral progestin formulations or comparing them to the Ling IUD. However, Megase or medroxyprogesterone are recommended in the majority of studies, and these are the most commonly recommended progestational agents, as I mentioned previously. In follow-up, the current consensus recommendation for follow-up is for those treated with progestational agents, gynecologists should perform repeat endometrial biopsies within 3 to 6 months of starting treatment. This is a table that I had put together with the data in the consensus guideline statement. And there are 4 responses to non-surgical management to hormone therapy, which include the top response of complete response, the second, decrease in the pathology findings from an atypical endometrial hyperplasia to a hyperplasia without atypia. Number 3 is persistent disease despite the hormone therapy, or number 4, progression of disease. So in a patient that has the result of complete response within a 3 to 6 months biopsy, continued treatment and rebiopsy at 3 to 6 months is recommended to a total of 24 months. At that time, if biopsy is negative, to consider stopping the treatment. In a patient with a category that has resolution of the atypical hyperplasia to hyperplasia without atypia, so that there is a partial response by biopsy at 3 to 6 months, the recommendation is to continue therapy and rebiopsy at 3 to 6 month intervals until complete resolution of the hyperplasia, and then again a 24-month total treatment is recommended before stopping. For the patient with persistent disease at the first evaluation of 3 to 6 months by biopsy, it is recommended to continue for another 3 to 6 months, but if after a 9 to 12 month period of time there has been persistent disease without resolution, then definitive management is recommended. And this is because of the risk of progression of disease, about 8% per year, even though on therapy. And if a progression of disease occurs to a cancer biopsy within the first 3 to 6 months, then definitive evaluation with surgery would be indicated. It should also be noted that even for the patient that had a complete response and resolution after treatment with 24 months of therapy with continued resolution, that the recurrence rate of epithelial, intraepithelial neoplasia or atypical endometrial hyperplasia is high. It is up to 23%, and thus these patients will need close follow-up. And again, for the patient with persistent disease or a cancer diagnosis on biopsy, then definite surgery would be indicated, and with a cancer diagnosis, consultation with GYN oncology for evaluation of sentinel lymph nodes would be indicated. Next consensus recommendation in follow-up is gynecologists may consider long-term maintenance therapy with progestational agents for patients who have had complete resolution of their atypical endometrial hyperplasia. And risk factors definitely play a role in this decision for follow-up. There are non-modifiable as well as modifiable risk factors. And the non-modifiable risk factors many of us are well aware of, between increasing age, late menopause, nulliparity, chronic anovulation, diabetes, Lynch or Cowdron syndromes, and obesity. As we are coming to understand obesity more, although we like to think diet and exercise may be the answer to everything, some obesity just is not controlled by or managed by diet and or exercise. If the patient's changes were caused by unopposed estrogen therapy, then that should be modifiable with the treatment as we have talked about with non-surgical versus surgical management. And obesity can sometimes be modifiable with weight loss, even including bariatric surgery. Another consideration in the evaluation and management of atypical endometrial hyperplasia is for the patient that desires future fertility. And it is encouraging to know that post-treatment pregnancy rates following successful treatments of endometrial intraepithelial neoplasia or atypical endometrial hyperplasia is from 31 to 41%. And assisted reproductive technology, however, is the most common way that women do attain a pregnancy that is successful. Finally, I want to make a few comments about counseling patients on lifestyle modifications. It is important for us to be frank with our patients sometimes regarding modifications, particularly those resulting in weight loss and glycemic control. These will not only improve the overall likelihood of maintenance of a successful reduction of endometrial intraepithelial neoplasia or atypical endometrial hyperplasia, and as well as improve their overall quality of health. Nearly 70% of endometrial cancer survivors have obesity of a BMI greater than 30. And most survivors are unaware that obesity and endometrial hyperplasia or atypical endometrial hyperplasia and cancer are linked. Even a weight loss of 7 to 10% for patients who have obesity have been found to have positive outcomes on their overall health, as well as reduced likelihood of recurrence of their endometrial intraepithelial neoplasia or reduce their risk of development of cancer. So in conclusion, my number one most important thing I want you to take home from this lecture is that office endometrial biopsy is great for diagnosing hyperplasia and or atypical endometrial hyperplasia, but if you have an atypical endometrial hyperplasia, hysteroscopic further evaluation and endometrial biopsy or sampling is important to confirm the precancer versus the cancer change. And this is because of the high association, up to 50% of endometrial cancer being present at the time of biopsy of endometrial intraepithelial neoplasia or atypical endometrial hyperplasia. Number two, hysterectomy is the mainstay of treatment for this disease. We spent a lot of time today talking about hormones and hormone treatment, but hysterectomy is the number one treatment. And no supracervical hysterectomy, no endometrial ablation should be performed. The non-surgical management with progestational agents is acceptable when hysterectomy is not an option or when fertility sparing is desired. And the superiority of oral versus intrauterine progestational agents, we really don't have that data, although what data we do have seems to favor the intrauterine device because in part of the decreased symptoms and side effects that patients have. For patients who are treated with progesterone agents, it is important to follow them with repeat biopsies. And even if their IUD is in place, you can still do an endometrial biopsy. Following initiation of progestin treatment, long-term maintenance therapy with progestational agents may be considered. And it is important to talk to the patients about lifestyle modifications if obesity is indeed a part of what has caused their atypical endometrial hyperplasia. So I do thank you for this opportunity to have shared this clinical consensus document with you today. And I really want to give recognition to the Clinical Consensus GYN Committee who put this document together. Thank you and have a great conference. Bye-bye.
Professor Vera Hick, for your excellent speech. Now open for floor discussion.
Thank you for Dr. Hicks' presentation. I remember I was in GBMC resident 50 years ago, the pathology of endometrial abnormality, that including simple hyperplasia, adenomatous hyperplasia, and atypical hyperplasia. Nowadays, the system, reporting system, becomes to EIN, just like CIN. And as we know, CIN 1, 2, 3 have the treatment guideline. And how about the EIN treatment guideline? Do you have or not? The second question, the pathologist will have the same opinion on this pathological finding. And the third question, what kind of concurrent disease or even the cancers with the EIN in odors? Thank you.
Well, first of all, I want to point out that I'm not Dr. Hicks. I'm Dr. DeFrancesco, and I'm standing in for her because she's on an airplane right now, as I understand it. But in any event, and secondly, I do have to warn you that I'm not a GYN oncologist. But let me start with your first question, at least. At this point, I think part of the purpose of this new paper, this new consensus document, was to demonstrate the concern. In a sense, EIN is more complicated and more subjective, probably, than CIN might be, or even VIN. So I think part of the concern ties in with your third question, And I think what Dr. Hicks was explaining was because of the concurrent presence of a cancer of the uterus, and I assume she means a deeper endometrial cancer that maybe you missed with a DNC, a simple curettage. You do have to be more aggressive and assume that that's why we wouldn't just do an ablation, we wouldn't just do a supracervical hysterectomy, because many times when there is just atypical, what we traditionally called atypical hyperplasia, there can be deeper cancers. And my understanding is primarily these deeper cancers would be endometrial type of cancers as opposed to ovarian or other sources. But again, my biggest caveat is I am not a GYN oncologist, and I don't do a lot of this stuff. I will, Dr. Hicks, I'm sure will hear these questions, and I'm sure there's some way she can get back a more complete answer to you. That helps. And I missed the second question. You said there were three.
The second question is that different pathologists will have the same viewpoint on the pathologic finding to agree each other for the EIN.
I'm sorry, I didn't understand that.
My question is because the EIN pathologists,
yes,
the different pathologists will have the same opinion on that. Agree each other.
Right. I think that's the problem. It's not that objective. It's not that black and white, and there is a lot of discretion on the part of pathologists, and I think that's part of the problem with EIN and with atypical hyperplasia is being sure that it's an accurate diagnosis. So to treat the patient most conservatively, in the sense of to protect the patient, we have to assume that it might be worse than it appears. So that's the reason of doing more biopsies and trying other ways to keep an eye on it closely, and just not do a simple ablation or something that could hide a cancer, in other words. But it's part of the difficulty of the EIN, I think, is the subjectivity of the pathologist. I hope that helped.
Thank you.
Okay, thanks, Professor De Francesco. Now move to the next speaker.
Okay,
thank you.
This time is limited, but we move to the next speaker, the final speaker of the AT Joint Conference. Professor Lisa, are you available online? Okay, good. Okay, let's introduce the Professor Lisa Hollier. Professor Lisa Hollier is the professor of Department of OBGYN of the Baylor College of Medicine. He also the past president of ACOG since 2018 to 2019. And the professor Lisa is graduated from the Tulane University School of Medicine. And also he have the master degree in the Tulane University of the Public Health and the Tropical Medicine. Professor Lisa contribute herself into the maternal safety. She now is work as the medical center of the maternal morbidity prevention, the team, and also is working as in the medical infant health branch, the division of the reproductive health. Also the chief medical officer of the children health plan in Texas. Okay, let's begin. Welcome the Professor Lisa Hollier. His topic is the management of postpartum hemorrhage. Please.
Hello. It is a privilege to have this opportunity to take part in your annual meeting. My topic for today will be management of postpartum hemorrhage. The learning objectives for this course are presented here. I have no potential conflicts of interest to disclose. Here we have the most recent estimates
on the maternal mortality ratios by country from the World Health Organization. As you can see, Sub-Saharan Africa has the counties with the highest maternal mortality ratios. This figure is based on data from the systematic review by Say and colleagues published in The Lancet in 2014 using data from 2003 through 2009. Hemorrhage remains a leading cause of maternal mortality. The American College of Obstetricians and Gynecologists defines postpartum hemorrhage as cumulative blood loss of greater than a liter or blood loss accompanied by signs and symptoms of hypovolemia within 24 hours after the birth process, regardless of the route of delivery. Blood loss more than 500 milliliters in a vaginal delivery should be considered abnormal and should serve as an indication for the healthcare provider to investigate the increased blood loss. The Alliance for Innovation on Maternal Health is a quality improvement initiative to support best practices that make birth safer, improve maternal health outcomes, and save lives. AIM develops multidisciplinary, condition-specific patient safety bundles to support best practices that make birth safer. Patient safety bundles are a structured way of improving the processes of care and patient outcomes. They follow an evidence-based structure that, when performed collectively and reliably, have been proven to improve patient outcomes. A bundle includes actionable steps that can be adapted to a variety of facilities and resource levels. These are the 5 R's that are included in all AIM bundles: readiness, recognition and prevention, response, reporting and systems learning, and respectful, equitable, and supportive care. This is what the bundles look like on the AIM website with the 5 R's and available materials, along with additional quick links with information on how the bundles can be implemented at local levels. The mission of the Joint Commission is to continuously improve healthcare for the public in collaboration with other stakeholders by evaluating healthcare organizations. They set quality standards and evaluate an organization's performance. Reporting and systems learning content highlighted in the Alliance for Innovation on Maternal Health, or AIM, maternal safety bundles informed the Joint Commission in developing standards for maternal safety to reduce the likelihood of harm related to obstetric hemorrhage. The Joint Commission standards for maternal safety were effective January 1st in 2021 and go beyond metric benchmarks and require leaders of hospitals, health systems, and birth facilities in the United States to examine the processes and procedures surrounding the care of women experiencing maternal hemorrhage. Let's start with readiness. Readiness emphasizes the need to develop processes for management of patients with obstetric hemorrhage. This includes a designated rapid response team co-led by nursing, obstetrics, and anesthesia, with membership appropriate to the facility's level of maternal care. A standardized facility-wide, stage-based obstetric hemorrhage emergency management plan with checklists and escalation policy. Emergency release and massive transfusion protocols to ensure immediate access to blood products. A protocol to collaborate with patients who decline blood products but may accept alternative approaches, and a review of policies to identify and address organizational root causes of racial and ethnic disparities in outcomes related to the diagnosis, management, and surveillance of obstetric hemorrhage. 2 key components of readiness are maintaining a hemorrhage cart or equivalent with supplies, checklists, and instruction cards for devices or procedures wherever antepartum, laboring, and postpartum patients are located. Also, ensuring immediate access to first and second line hemorrhage medications in a kit or equivalent per the unit's obstetric hemorrhage emergency management plan. A A hemorrhage cart centralizes all of the supplies commonly used in the treatment of obstetric hemorrhage, significantly reducing the time needed for support staff to locate supplies. Staff are able to stay at the bedside where they are most needed, and the care of the patient is streamlined. For ideal response to the emergency, the team should have rapid access to medications, devices, and surgical instruments designed to treat postpartum hemorrhage. Equipment and instruments contained in obstetric hemorrhage carts and trays are designed to perform uterine tamponade and repair vaginal and cervical lacerations. Carts throughout the facility should be identical so that the OB rapid response team can move seamlessly through the emergency with ready access to all supplies and equipment. Next, conduct interprofessional and interdepartmental team-based drills with timely debriefs that include the use of simulated patients. Simulation has the potential to decrease maternal morbidity and mortality by providing an opportunity to assess system weaknesses, identify opportunities for improvement, and test new or modified policies and procedures. Simulation involves the entire team practicing in a realistic environment wherein the focus is not on a live patient, but on the team, learners, and methods. Because hemorrhage is an infrequent event, simulation can provide an opportunity for teams to maintain proficiency and identify systems issues that impact care. Participants have the opportunity to practice skills in team communication to improve readiness and collaborate, identify issues or concerns and barriers to care, all while in their actual working environment. Simulations also offer participants a safe space to practice how to communicate with the patient and family during an emergency, and the debrief addresses any gaps in team performance. It is critical that areas of care that have less opportunity to develop skills associated with identifying and responding to hemorrhage, such as postpartum units, participate in simulations and drills. Moving to recognition and prevention for every patient. First, let's talk about addressing and communicating hemorrhage risk. If a patient is identified as high risk for obstetric hemorrhage, experienced staff and key resources can be mobilized in advance of the delivery. Decisions about the timing, mode, and location for delivery may be influenced by each patient's risk. For example, patients at high risk for severe hemorrhage, such as those with placenta accreta spectrum, may be advised to plan to give birth at a center with a higher level of care that has in-house surgical and anesthesia staff, a well-stocked blood bank, and the necessary equipment and resources for managing severe obstetric hemorrhage. Performing risk assessments at admission, at the onset of the second stage, and at transfer to postpartum may allow the maternity team to better prepare for the majority of hemorrhages. Although no risk assessment guide has been proven to capture every patient who experiences an obstetrical hemorrhage. Several risk assessment tools have been promoted by maternal safety agencies, including the California Maternal Quality of Care Collaborative, the Association for Women's Health Obstetric and Neonatal Nurses, and the Safe Motherhood Initiative. This is an example of a risk assessment from the California Maternal Quality Care Collaborative. It is important to recognize the signs or symptoms of considerable blood loss. It's also important to remember that these signs and symptoms may not present or may not present until the blood loss is substantial. Maternal early warning systems with clinical triggers are increasingly implemented in healthcare settings. While absolute numbers such as those in this example are important for early maternal warning systems, it is also important to remember that there may be situations where the vital signs do not meet these criteria, where additional intervention is warranted. Let's move to quantitative rather than qualitative approaches to cumulative blood loss. Routine quantification of blood loss is an important step in assuring that there is a more precise estimate of blood loss. While there is limited data on clear clinical improvement with the implementation of quantitative blood loss systems, replacing that visual estimate of blood loss has been proposed as one of 7 safety objectives of the National Maternal Health Initiative. Quantitative cumulative blood loss is a key component of stage-based assessment of obstetric hemorrhage, and the bundle recommends that quantitative assessment be implemented as a routine practice on all units caring for obstetric patients, and therefore all facilities should provide resources and standardized education on the calculation and documentation of quantitative cumulative blood loss. Next, we'll talk about active management of the 3rd stage of labor. Evidence-based analysis has established a clear benefit of oxytocin prophylaxis in the 3rd stage of labor for reducing maternal hemorrhage, but studies evaluating the individual other components of the active management of 3rd stage of labor have not clearly demonstrated benefit of non-oxytocin components, including uterine massage, immediate cord clamping, and cord traction in low-risk women. The World Health Organization recommends prophylactic oxytocin for all women, advises against sustained uterine massage for hemorrhage prevention when prophylactic oxytocin has been used, and recommends delayed cord clamping for all births unless there is an immediate need for neonatal resuscitation. Let's move to response. Response for every patient includes the use of a standardized, facility-wide, stage-based obstetric hemorrhage emergency management plan. Plan elements should include the preparations that should be made upon hemorrhage risk assessment, plans for evaluating the etiology of hemorrhage, OB rapid response teams, and evidence-based management. First, some very simple strategies. Call for help. This may be the activation of your obstetric rapid response team. Ensure that sufficient blood products are available. Ensure adequate IV access. We'll talk about searching for etiologies of hemorrhage, and we'll also talk about uterotonic agents. You may need to activate the massive transfusion protocol at your institution based on your obstetric emergency management plan. An indwelling catheter can help to monitor urine output. Finally, obstetric operative management may be required, but I'm actually not going to address operative surgical strategies today. A systematic approach to identify the cause of hemorrhage is important, and a checklist to support this process is recommended. Performing a thorough examination of the vagina, uterus, and abdomen, and potentially assessing coagulation status are critical steps in identifying the cause of hemorrhage. Although the majority of obstetric hemorrhage is related to uterinectomy, other causes like vaginal and cervical lacerations, hematomas, uterine rupture, abnormally adherent placenta, uterine inversion, and coagulopathies are all included in the differential diagnosis. Remember, more than one issue can simultaneously contribute to hemorrhage. To have the best chance of preventing the progression of heavy bleeding to massive hemorrhage, all these possible etiologies should be considered. Experience suggests that an obstetric-specific rapid response team, or OB-RRT, can have a positive impact on patient safety, and this is supported by evidence. An OB-RRT with a standardized mechanism for activation ensures a standardized response of appropriate personnel to obstetric-specific emergencies and provides situational awareness to the rest of the unit that a critical event is occurring. Hospitals that utilize a hospital-wide rapid response team to respond to obstetric emergencies should be sure to include these teams in simulation and training so that there is no role confusion among team members. Uterotonic medications should be used aggressively in an effort to minimize blood loss and to prevent the need to progress through the hemorrhage algorithm. If there is a poor initial response to oxytocin, providers should have a low threshold for transitioning to a second-line uterotonic agent. There are no prospective studies comparing the efficacy of methylorgonavine versus carboprost. However, in an observational study of more than 1,300 women who underwent cesarean delivery, women with uterine atony who received carboprost had a 1.7-fold increased risk of hemorrhage-related morbidity compared to those receiving methylorgonavine. In the absence of contraindications, these data suggest that methylorgonavine may be the preferred second-line uterotonic. Recent data has called into question the role of misoprostol in the management of postpartum hemorrhage. 2 large randomized control trials demonstrated oxytocin had the best efficacy for both prophylaxis and first-line treatment of postpartum hemorrhage caused by uterine atony. In a recent Cochrane review, the conclusion was that giving misoprostol together with oxytocin probably does not improve effectiveness and merely increases the likelihood of significant fever, diarrhea, and vomiting. Based on this data, the use of misoprostol as a second-line uterotonic can no longer be recommended. It may be reserved for those patients with contraindications to methylorgonavine or carboprost, such as those with hypertension or asthma, or in a birth setting where other uterotonics are difficult to maintain or stock. When misoprostol is administered rectally compared to oral or sublingual routes, it takes a longer time to reach maximum serum concentration. Therefore, this route, rectal, is not recommended in the setting of postpartum hemorrhage should misoprostol be utilized. Tranexamic acid, or TXA, is an adjunctive medication and can be considered for all episodes of postpartum hemorrhage. TXA is a lysine analog and antifibrinolytic agent and may reduce bleeding in the setting of coagulation abnormalities. The Women International Randomized Controlled Trial showed a 31% reduction in death from hemorrhage when 1 gram of TXA was administered intravenously within 3 hours after the diagnosis of postpartum hemorrhage in women who had a vaginal or cesarean delivery. This is an example of a table that contains dosages, routes, contraindications, etc. This is a helpful tool that can be placed on the hemorrhage cart to facilitate treatment in emergencies. Indicators for blood product replacement include evidence of hemodynamic compromise and significant and ongoing blood loss. If transfusion therapy is delayed or if inadequate blood product support is given to patients with a major or life-threatening hemorrhage, then there is a significant risk of major morbidity from severe hypotension, severe anemia, and coagulopathy. Of note, in the bleeding patient, you do not need to wait for laboratory results before you begin transfusion. Moving to emergency release and massive transfusion protocols. In an emergency release protocol, at least 2 units of packed red blood cells are immediately released from the blood bank and brought to the bedside. If the patient has already been typed and cross-matched, use cross-matched blood when possible. If the patient has not been typed and crossed, do not delay transfusion to wait for cross-matched blood. In this scenario, the use of uncross-matched O-type blood is recommended. The massive transfusion protocol is recommended at each institution. And in this case, it provides a large amount of blood products at the same time, which gives providers the opportunity to keep up with the pace of massive blood loss so that the patient has appropriate replacement of those blood products. Let's move on to balloon tamponade. Tamponade has been demonstrated to be effective in controlling hemorrhage in 87% of acne-related cases. Successful use of a balloon catheter is defined in most case series as diminished bleeding such that no additional non-pharmacologic interventions are needed. Post-procedure monitoring includes continuing with the hemorrhage protocol, including the cumulative measurement of blood via the drainage bag. A plan for next steps needs to be created early in the process in the event that the balloon is ineffective, and consideration for ultrasound post-balloon placement can be used to ensure that blood is not collecting behind the balloon tip. Reported success rates again range from 68 to 88%. While the maximum indwelling time for uterine tamponade is generally 24 hours or less to reduce concerns for infection and tissue necrosis, consideration for removal of the balloon at 6 to 8 hours is encouraged. The intrauterine vacuum-induced hemorrhage control device was specifically designed to offer rapid treatment by applying low-level intrauterine vacuum to facilitate the physiologic forces of uterine contractions to constrict myometrial vessels and achieve hemostasis. The goal of placement is to place the intrauterine loop within the uterine cavity with the donut-shaped cervical seal just outside the external cervical os at the top of the vagina. This limits vacuum application to the uterus only. The volume of blood initially evacuated from the uterus and any ongoing blood loss is quantified in the canister during treatment. The device is typically left in place with the vacuum applied for approximately 1 hour after hemorrhage has been controlled. In a study of 106 patients who received the vacuum device, the device was considered to be 94% effective in controlling hemorrhage, defined as the first report that abnormal bleeding had been stopped. Uterine artery embolization. Uterine artery embolization can be used in selective situations with a hemodynamically stable patient who has persistent slow bleeding that has not responded to the non-invasive treatment options that have been used. Success rates range from 58 to 98% in clinical trials. However, there are some warnings. Complications have been reported from the placement of prophylactic arterial balloon devices in cases of known placenta accreta spectrum and after the use of uterine artery embolization to treat hemorrhage, including ischemic complications such as uterine necrosis. One should use these techniques only when there is sufficient expertise available and after a full review of the risks and benefits with the patient or surrogate decision maker. Uterine artery embolization techniques can be considered for a specific subset of patients receiving treatment in centers with adequate interventional radiology expertise, and routine use of prophylactic balloon catheter occlusive devices is not recommended. Bundle activities don't end at the resolution of the acute hemorrhage. It is essential to debrief after the events to understand what worked well and to identify opportunities for improvements. Serious complications, including severe maternal morbidity, should be tracked and reviewed by a multidisciplinary team on a regular basis. A feedback loop for all participants, including the rapid response team, care providers, and facility stakeholders, is important to inform care and change care systems as necessary. Concluding the bundle are principles for the provision of respectful, equitable, and supportive care on every unit by every provider and team member for every patient. Include patients and their support network as valuable contributors to the multidisciplinary team. In addition, it is empowering to engage patients and their support networks in open, transparent, and empathetic communication. This is true before, during, and after the events to ensure shared decision-making. In some cases, it may be necessary to have more than one discussion with the patient and her support network to ensure their understanding of events. Data on national implementation of the hemorrhage bundle is limited. However, we do have evidence of improvements from some large states. This is data from the California Maternal Quality Care Collaborative. Compared to a baseline period, women with hemorrhage in collaborative hospitals after bundle implementation experienced a 21% reduction in severe maternal morbidity, while women in comparison hospitals had a 1.3% increase. Women in hospitals with prior hemorrhage collaborative experience had an even larger reduction at 25.3%. These are the conclusions after implementation of a hemorrhage program in a large hospital system in Illinois. They found that the effects of the bundle implementation were sustained over a 4-year period. Of note, after the implementation, postpartum hemorrhage was more likely to be diagnosed, judged to be of greater volume, and the use of treatments was increased. The result was a decrease in ICU admissions over the time period. The authors concluded that postpartum hemorrhage was more readily identified and treated. Thank you very much for this opportunity to discuss strategies like the AIM Obstetric Hemorrhage Patient Safety Bundle that address postpartum hemorrhage, a leading cause of maternal mortality.
Thank you, Lisa. It's not online? Okay, Professor Lisa, good night. I'm the Professor Huang. It's excellent and informative speech. In Taiwan, we have the childbirth accident no-fault compensation system. According to our data, 1/3 of women die from the PPH, maybe 30%. Yes. So we now cooperated with our joint commission to developing the PPH bundle with 4R, not 5R. Okay. So it's very important to introduce the system to the birth center. So, any question from our audience? Okay, may I ask a question about your AIM have the PPH bundle. How can you introduce the bundle for your birth center, especially the level 1 birth center? Is it just only the fewer medical staff in their center?
For birth centers specifically, as opposed to labor and deliveries, what we've done in the United States is really a very broad implementation among groups who are especially interested. So a group of the willing. There are so many opportunities for our quality leaders to work with our hospital partners to do these implementations. And we've been able to implement these bundles in birth centers, actual birth centers. We're in fact doing that in the state of Texas, and also implementing them across labor and delivery units of all sizes, from the very small rural facilities up to very large academic medical centers with all of the capabilities. And I think that's one of the wonderful things about the way the bundles are built, is that they are adaptable to facilities of all different sizes and different care capabilities.
Yes. Okay, any question? Okay, good. Please, use the microphone. Your left side. Microphone.
Excuse me. Did you ever heard that some billionaire in America now exchange the whole blood to revitalize, to make younger, and maybe this kind of messy hemorrhage, just like exchange the whole blood of body. So, do you see any beneficial result? Have you ever heard of that?
No, I'm afraid I have not heard of that. It sounds interesting, but I have not heard of that. I am so sorry.
I haven't to see in a television program, so I'm very interested.
I'm so sorry that I don't have any information about that. I apologize.
No.
Okay, if no question, we have big hands to thank the Professor Lisa. Thank you so much. Okay, thank you. Okay, finally, we will invite the Professor Chen Shiyuan for closing remark. Okay, thank you.
好，那这个台美的这个 conference 是从去年黄敏昭院士还有这个美国的 Mark， 然后一起把这个美国的他们妇产科医学会很好的讲者来跟我们做交流。那我希望这个会议呢，我们都会一直传承下去，让我们跟台湾跟美国之间的关系，学术上还有友谊上，都能够永远的更上一层。那今天谢谢线上还有在座的参加，那线上也很多人收到这个明照的讯息哈。我们现在住院医师还有主治医师渐渐的都有这个赖群组，他们收到以后都很踊跃的来参加这些活动。那今天会谢谢大家，谢谢。